Thank you, Raymond. I'd like to invite the three speakers who are here up to the podium here, to the microphone, so we can have a little bit of a give and take here, and perhaps raise some stimulating thoughts. So, a few comments. We know that, I think, right now we have a sort of negative atmosphere in this country, anyhow, in terms of doing screening tests. Tests apply to large numbers of people. PSA, why bother? We haven't shown that using it can save lives. Mammography has recently come under the microscope again. And the U.S. Preventive Services Task Force has, in its wisdom, turned thumbs down really on both these modalities. And of course, they've been very anti any screening test, really. So, it's been also said by some of the panelists that one of the problems with Framingham Risk Score, which in a sense really is a screening tool, why not apply it to everybody, is that it doesn't work very well. And perhaps even more importantly, it does not help the individual practitioner from dealing with the individual patient who's sitting in front of him. You can't plug him into a formula and say, based upon this, you have a low, intermediate, or high risk, because these are the average risks in large populations of people. And I think we would all agree that if a patient came to your office and said, tell me what my risk is, and he was 45 years old and he had a cholesterol value that wasn't so bad, you're not going to say to him, I'm sorry, by the Framingham Risk Score and current guidelines, I'm just not going to do any further testing on you because you're at low risk. Does not that patient have a right to know? So this is one of the topics that I want to raise for the panel. And then also, if we have a test, whether it's coronary calcium or carotid IMT, that we know is superior to other existing methods for evaluating risk, and we know that we can effectively treat high-risk patients, every statin trial has shown that, do we need a randomized trial demonstrating that the use of these parameters decreases the outcomes? Or is it enough to say, I can identify 95% of the people, using, for instance, coronary calcium, who are going to have an MI. Why shouldn't I identify these people? And even if I did a trial which showed me that the use of coronary calcium did not save lives, well, isn't that the fault of the treatment rather than of the test? How can we argue against identifying high-risk patients for the biggest killer in this country? So these are a few of the thoughts that I'd like to ask the panelists to address. And even though screening is not the title of this symposium, if the various participants could address the question, is it time to do a screening test for coronary disease? In Texas, we immunized teenagers for papillomavirus. It's mandated by the government. Should we mandate that every person have a screening test for coronary disease? Dr. Wright or Dr. Irvin, you want to start? Go ahead.
Well, I think if you're talking about an imaging test, the answer would obviously be no. Well, I don't think anybody's talking about its use as a screening tool, which would be, I think, a kind of a general population-based tool. But what I think the data that suggests makes sense is that in the patients who are defined as being at intermediate risk, whether we use that 3% cutoff or the 6% cutoff, that further definition of the level of intensity that we need to use in their therapy just seems to make sense. And when it makes sense, I question whether we need a large randomized trial that's going to take 10 years to come up with the data. I mean, we know that in secondary prevention, aggressive therapy works. We're identifying something that has the same risk when there's elevated scores as having a paramyocardial infarction. And we know that we have very effective therapies at reducing heart attack rates. I think that the data are existing data, compelling enough that I think the guidelines getting increasingly more accepted without a randomized trial just seems to make sense.
But Dan, aren't you really saying then, maybe it's just semantics, aren't you saying we should screen the intermediate risk population then?
Well, it might be semantics, but I think the word screening has a connotation of being something that would be applied to the whole population, like measuring their blood pressure. So that's why I think that probably people in our various positions of really policy making in the country would probably,
It's a dirty word, huh?
That might not be right.
It's only 40 million people in the intermediate risk population.
Yes, so Dan, I agree, and couldn't have said as well as you just did. Well, what I think is a reasonable position, I have to just sort of say that I've never appreciated the value of research more than I do now. Because it is the research and the evidence generation that then affects the guidelines, that then drives those recommendations. Obviously, there are concerns around screening large numbers and the cost of that. So I just want to say I was so pleased to see the economic data coming out in the studies that you've shown tonight, because that is part of the argument. It's not the only argument, but it is something that we have to consider.
May I add another point? Going back to the head of the Department of Cardiology who died in Hanover, he was aware that he was high risk because he had a family history and he had problems with cholesterol. But he did exercise very enormously. And I had with him a lot of discussions 6 weeks before he died, because we want to do a high nationwide screening in a study in Germany of 200,000 people. And I was for the sub-study with CT, and he denied the necessity. He said it's more high risk of X-ray exposure and so on. Now, I think that those who do in this age high-intensive sports should undergo screening. Because when you remember in our Heinz-Rico study, we found in 6 to 8% silent myocardial infarction already by ECG. And in the marathon runners, we had a group of marathon runners, 108, matched with the Heinz-Rico study. There we found by MRI 12% silent myocardial infarction. And everyone in Germany or Europe knows that when you go to these events, there are always occurring myocardial infarction, there are always occurring deaths. And I think you can even ask for pilots. You can take for those who get in the mountains, mountain climbing. Yeah? This is part where we have a little more individualized analysis. We cannot say for everyone we only do it by intermediate risk. I think there are a group of people who are at high risk. My friend was 60 years, became 60 years, pilot, and says, oh, I have an offer to fly the Jumbo to Hong Kong. What do you think? I'm healthy, because he was afraid to get a myocardial infarction, because this is very much discussed with pilots. And we did a scan, 0 calcium. I said, go, you can do it, no risk.
Well, let me come back to the widespread use of age screening technology. And of course, if we're concerned about radiation, that is much less of a concern now with coronary calcium. We're really in the sub-millisievert range for coronary calcium score, which is roughly equivalent to mammography. And with IMT, there's no radiation whatsoever. But if we go back years before cholesterol was used, before Framingham risk score was used, and we had a measure of subclinical atherosclerosis, would we not say, that's what we should use? The best evidence, the best risk for atherosclerosis is a demonstration thereof. So why are we still paying such attention to the Framingham risk score? Why, when it's know your numbers, why is it your LDL? Why isn't it know what your carotid IMT is, or know what your coronary calcium score is? If those numbers are exponentially more powerful than the conventional risk factors in predicting your risk. Yes, it does involve a mindset alteration to change dramatically the way things have been done in the past, but if we feel strongly that it's the correct way, then why don't we do it? And specifically with regard to the Million Heart, is there any contemplation given for certain subsets of these patients to incorporating a test for subclinical atherosclerosis?
So Million Hearts is not going to practice medicine. You'll be relieved to know that. So we will be tracking the evidence and the guidance that comes out of the major guideline generating groups. And that's, again, why it's so important for those of you who are doing research or contributing to the evidence base to keep doing that.
and possibly at the moment cholesterol and blood pressure and so on are anyway determined in the office. So when they have the numbers, they play around and calculate the family risk score anyway, because they need it for treatment, you know. So I think it's not the real question only to do it. I think it's to emphasize and to get in the public the knowledge, plaque burden counts. When we see the plaque burden between men and women, you see no difference. The event rate was 8.3% in men and women when the calcium score was more than 400. And we have a paper in hypertension, which will soon appear, where we looked to hypertension and calcium scoring. The main predictor of risk, and now 7.8 years follow-up already, was coronary calcium, not the JNC7 classification of hypertension. So again, as you said with diabetes, there are people who have no calcium. There are people who have high blood pressure, have no calcium. And even in pre-hypertension, we could find an additive value of plaque analysis by calcium scoring. And that is fascinating, you know. Because we have this study, this is said it's higher risk, but then there was a study done with ACE inhibitors in the New England Journal of Medicine published, and it was negative because the side effects were higher. But when we now do this again only in those with high pre-hypertension who have high calcium scores, possibly a different result of such a study would come out.
And then related to your point, we have the issues of compliance. So both with blood pressure medications and with ACE inhibitors and with aspirin, we know that compliance is just nowhere near what it should be. And the data does suggest that we can improve that with the visualization of atherosclerosis. And I think putting together tools such as the atherosclerosis imaging with other methods of getting through the patient, both from the physician and coaches and internet and press and all the things that you're thinking about are going to potentially make a very large difference. I want to just make two other points. One is that in my comments I didn't mention Heinz Nixdorf because I was asked to talk about the United States perspective, and I didn't mean at all to suggest that MESA had any kind of superiority over any other trial. I was just using MESA. I was asked to talk about the United States, and I had left for the European experience. And the other thing was just coming back to Harvey's question. I think it has to come down to cost. If a carotid IMT or a coronary calcium scan was $20, essentially the same as it costs to do a blood test, I'm sure we'll be using it as a screening tool. It is down to probably on the average in the United States, probably 100. If you looked at all of the different ways in which these studies are being paid for. And I believe in coming down, at 100 and coming down. And carotid IMT is similar. So as we get the cost down, then the likelihood that we will be much more widely adopted for an expanding group of patients would be increasing.
But Dan, as you pointed out, once you drop the calcium score cost to 100, then coronary calcium is far more cost effective than treating all or the ATP3 guidelines. So are we really not there already?
I think that we have to get Janet involved in this discussion. I think that we need probably to work with you in being able to show this cost effectiveness and to do it maybe in parallel or as part of sub-studies of the Million Hearts and be able to demonstrate this in order for it to be put into effect. But I think that getting people like George Diamond and his son Jay Call to now reanalyze with the $100 cost and publicizing that would be a very good idea. Maybe we're closer to adoption than I'm suggesting.
Any thoughts about a polypill approach? Janet, perhaps addressed to you, would this not be a convenient way to take care of the ABCs?
Well, what I understand about the med adherence with polypills, it's improved over, and you know it from your own experience, but I don't have any real scientific experience with that. How do you have
I think it will come. So the polypill will come, and many efforts are done in the WHO and the WHF to get to this point. But again, we cannot treat everyone, and I think that would not be ethical to everyone to get a pill at the age of 50. So again, here we have to do a selection: who will do it and who will get it, because there is a risk and benefit which have to be taken into account. Yeah, also aspirin is not only without risk; there is a risk. And this has really to be matched. And I think somebody here with 50 years now take until your end of your life the polypill, or he gets a chance first to see if he is ill. He will select, I think 90% of people say, first we do the examination and then treat me, but don't start with treatment without the diagnosis. That is, I think, ridiculous.
A question for Dr. Wright. So the initiative, the Million Heart Initiative, is a 5-year initiative for a million, and you even divided by 5 years, each year 250,000.
And this is week 252, just because you should know that. I only got 252 weeks.
250. So with that in mind, any kind of intervention that is going to have an effect 20 years later, like reducing trans fat or reducing blood pressure at a certain very minor level, we know the effect has to translate into plaque, complication of plaque, after thrombosis, MI, and so on. And all of these take a long time. Whereas if you look at what we call vulnerable patients, these are patients who are, as if you imagine, they're going on a path to fall off the cliff. The ones that are closer to the cliff, to the edge of the cliff, are probably makes more sense to focus on them if you want to try to reduce the event in 5 years or 1 year. Has there been any discussions in your group that, okay, we're going to approach this, there are people who are going to have a heart attack in 30 years, 20 years, reducing their fat, dietary fat, and other risk factors is important. But there are people who are going to have an event in the next year or 2 years, and these are really close to the edge of the cliff, and we consider them the vulnerable patient. So has there been any discussions in your group?
So part of my get acquainted process has been to go to federal agencies and sit down with their Million Hearts team or Million Heart contact and understand what their work is. So last week I met with SAMHSA, and I didn't know SAMHSA at all before this new job. SAMHSA stands for Substance Abuse and Mental Health Administration, Mental Health Services Administration. See, I'm still working on it. So I met with SAMHSA folks and understood the statistics, which are stunning, about the risk of cardiovascular disease in those who have serious mental illnesses. It is over the top, as is their tobacco use. General population, 19-20%. In those with serious mental illnesses, 75% smokers, for example. So the gauntlet that they threw down to me is that they want to deliver 1/3 of the prevented heart attacks and strokes in the mental health population. Mental illness population. The following day, I met with the CMS. The CMS has a new office on minority health. All of the major agencies have offices of minority health, and now there is a national racial and ethnic disparities agenda at the HHS level. The Office of Minority Health at CMS threw it down again and said, we want to bring 1/3 of those lives saved from those in racial and ethnic disparities populations. So that kind of thinking is going on. What I'm not in full possession of yet is how to, right. But the first thing is getting the focus, right?
Yes.
So the initiative is going to focus on the ABCs. then people are going to declare what their intentions are within their own sort of field of view. And the next step is, what actions are we going to take with those populations?
So there is an agenda to focus on these very high-risk populations?
Yes.
That basically, seed will really not work. You reduce cholesterol today, it's going to take a while to reduce plaque and do
Right.
some other things. And same with blood pressure. Aspirin can help with atherothrombosis, but we all know it's very minor in terms of affecting on plaque coagulation and thrombosis and so on. So if we find those people who have, for example, in Dan's study or Raymond's study, if you find people who have chloride calcium of 1,000 and more, or people who have a carotid endometrial thickness of 1 or 1.5, these are like walking time bomb. And we just let them just walk and just tell them, take an aspirin and measure your blood pressure. And we say the same people other people who are, their chloride calcium is 0, their carotid is like baby's carotid, it's so thin. And we tell them, well, watch your cholesterol and take aspirin. Don't you think we're just doing blind approach here? And we could a little bit improve it by just focusing on those people who are, quote unquote, a walking time bomb. I mean, in terms of carotid, it would be a simple screening without radiation. In terms of coronary calcium, probably another layer, a more sort of focused version. I'm sure you guys have thought about it. It's impossible that nobody, this is almost, it's not rocket science, it's very obvious. There are people who have lots of plaque and they're walking, and we're going to try to prevent them in the next year or next 5 years. Do you think there will be discussions if there have?
There'll certainly be discussions. There have been a lot of thought that has gone into the design of this to date, but I think there will be continual refinement. It's a 5-year, I would say, a marathon, but it does feel like we need to sprint through that marathon. Again, I hope that you continue to publish, share your experience, tell us what works, what doesn't work. One of the things we're looking for are success stories and best practices. So as you identify those, please let us know so we can help shine a light on those.
Mort, I think you make a very good point, and what Janet's response, I think, is that they are focusing on high-risk groups. I think that the SHAPE impact could be to mobilize the community that is using this kind of imaging to define another kind of high-risk cohort that could be added to the other ones that she's already brought up, that would be very fruitful groups to focus attention on. It's probably, I think what Mort suggested, maybe putting resources into those patients with mental health issues, putting resources into the smokers of America, and maybe putting resources into the patients with high-risk atherosclerosis would allow the short-term, relatively short-term goal to be achieved.
Yeah.
Low-hanging fruit.
Yeah, low-hanging fruit. A few examples. I mean, you just brought up this mental group, which I didn't think of it that would be high risk, but obviously it is. Firefighters, they have almost like 8 to 10 times more risk of having heart attack. You could just announce that firefighters that they have to make sure that their people are clean coronaries. If they're not, they get the treatment. So ABC would be enforcing firefighters more intensively than others. The other simple initiatives that you can have is people are going to get their driver's license. They can't get their driver's license until they measure their blood pressure. It's a simple thing. Just manage blood pressure and all of this. And once they know their blood pressure, there will be a tag, high blood pressure. Obviously, a lot of them will be borderline or normal, but then you find a lot of people are totally unaware and they have very high blood pressure. The same for employment exam. This is a national thing, everybody do. We still go and get an exam for TB. You use that much X-ray to find coronary calcium, but TB is not killing people. What's killing people is coronary events. So a few of these small ones can make a huge difference, and obviously we would love to contribute to SHAPE in any way we can.
Yes.
I usually get calcium score with almost every stress test that I order. So I'm going to be ordering about 4 calcium scores a day. And on symptomatic patients. And that's mostly based on Dr. Berman's research showing that if you have a negative stress nuke, that you have a very strong chance of having a positive calcium score, even over 100 or even higher. And I'm one of the very, very few in my community who does that. And so I think the symptomatic patients referred to the cardiologists frequently should be getting calcium scores instead of being told they have a negative stress test. And does SHAPE have anything to say about that?
I think it's a very good point. I think SHAPE is focused on the asymptomatic population, the much larger asymptomatic group. But how we deal with the symptomatic patients also needs to be improved. So often, as you're pointing out, patients will get a negative stress test, whether it's an ECG, a nuclear scan, a stress echo, and be given a clean bill of health, when in fact they may be harboring extensive atherosclerosis. We found over 50% of patients had, in our group with normal nuclear scans, had coronary calcium scores over 100. And 30% or so had coronary calcium scores over 400. But I think that so I think that what you're pointing out is another area potentially of low-hanging fruit. And that would be to educate physicians that normal stress tests aren't enough, and that there is that the subclinical atherosclerosis worth going after.
Dan, I'd like to, Janet, your comments about increased incidence of disease in mental health people disturbing. Dan, you and I better go out and get scanned pretty quickly. Another part of the equation, before I go to that, Janet, in the Million Heart Program, you talked about the physician involvement. And it seems to me that, certainly in the past, it's been very easy to understand why physicians have not been too attentive to preventive cardiology, because it paid nothing. They could earn much more doing imaging tests, stress testing in their office, or doing caths, or putting stents in. And perhaps the bloom is off that rose now with decreasing reimbursements, but what can we do to motivate the physician, the cardiologist, even though most of these patients should be attacked in the primary care office? But what can we do to motivate all physicians, primary care, internists, cardiologists, to place much more of an emphasis on establishing the risks of their patients and treating them?
So, I think what motivates us, primarily what motivates us, is that we want to see some good outcome for the person we're taking care of. We want them not to have pain, we want them to feel better, we want them to live longer. That's very satisfying work. The way our reimbursement system has been perversely designed over the last number of years is not to reward the kinds of conversations and interactions that actually might lead there, but to skew our time, our minutes spent toward the procedures. And as you say, that's changing now. So there's a recognition that the time with the patient, that the conversation, that the behavior modification, those things are really valuable. Are we completely shifted there yet? Not yet. But there is recognition that there is a cost involved to coordinate care. And so these medical home models that are popping up all over everywhere are trying to recognize that a different kind of care where there's more continuous contact with the patient, not always related to an office visit, maybe doing telemedicine or more fluid outreach with patients might be a better model. That's also ideally configured to connect the primary care doctor and the specialist in a way that we haven't really had up and functional outside of systems like Kaiser and a few others. So I think there's a shift afoot. You and I were talking about this wildebeest migration of cardiologists that occurred 2 years ago, where many of us went from a private practice setting to hospital employment. I think we'll be determining the impact of that for some time. But overall, how can we incent doctors to get more interested in prevention? I think it is about the reward of seeing an impact on your patient. What the system can do to help reinforce that is incentive. incentive with money and with recognition, and also with hassle reduction, which is part of what the simplification and alignment of those measures is all about, so that we're not driven crazy by different measurements by different entities.
I was fascinated by your statement, and I thought about that would be very nice when I could see it also. And Harvey sometimes mentions this also, that we have not the knowledge of how are doing my own patients overall. That's a very good remark, and I like this idea to get this data. And I will explain to you an example. In the University of Hanover, where Dr. Drexler is working, and he didn't know about checkup and so on, and didn't do CT. In 1.5 years, 4 members of the medical faculty, leaders of the departments, pediatric cardiology, immunology, died on acute myocardial infarction. None in Essen. It's just luck, but you know, to observe in the newspapers, the last one died in July this year, in working ages, so before 65 years, that in such a faculty so many people died. That is going in this direction. We should have, and that could be a quality control, and then the re-assessment for the physicians. It may be a good possibility to check up this event rates in their population of the praxis, or the community or whatever. There may be big differences.
Well, actually, Dr. Ndawi pretty much elegantly covered what I was going to say, but just to reiterate that point, I think the goal, 5-year goal, and the method to achieve it, I'm afraid they don't seem aligned to me, just like what Dr. Ndawi is saying. That what you're treating are risk factors over the next 5 years. It may have some incremental reduction, but it's not going to have a drastic reduction. And you talked about, proven methods or some better, evidence out there. I would suggest, you can just look at the National Health Service. They implemented a 10-year goal to reduce mortality rate from cardiovascular disease. They achieved a 40% reduction in less than 5 years. And it had nothing to do with ABCs. It had all to do with process improvement of people who already have had a myocardial infarction or some other heart event, how to handle that patient from there on. Okay, so I think that, what Dr. Ndawi is talking about, is there are people already very close to the edge, and there are people who have already fallen over the edge. If you want to achieve your 5-year goal, we need to look at that first, focus on that area. And the 10-year, 15-year goal, I think the ABCs and all that, I agree with you, which probably will fit in very nice.
But I think what I hear in your statement is the idea that folks who need secondary prevention would not be included in the ABCs, and they certainly are. We're not saying only virgin people get counted or treated for the ABCs. So this would apply to secondary prevention also. I understand what you're saying, that we could accelerate the success of this by focusing on the high-risk patients.
I just think that you need more than just the ABC stuff.
I think you just prompted an idea I wanted to share with you. If you, so you're right, half of our heart attack comes from the asymptomatic population, grossly. The other half are coming from people who had the first heart attack.
10%.
I'm sorry?
10%.
Well,
Uri published this in New England Journal of Medicine. In the public, where we have high risk population after myocardial infarction, low ejection fraction, there's only 10% of those who die in the general population.
yeah, there are 10% of
Therefore, we have more to persist. As Monica said, on primary prevention, that is a major event. There are much more deaths than in the high-risk patients. So we have to I agree when we say we have to concentrate on high-risk people,
That's right.
but not patients.
Right. So let's assume we have
Yeah, of course.
we have there are several studies coming out, and I agree with you, there are variations. But let's assume half of them comes from people who had prior heart attack, and they come in with advanced work, but the other half are totally asymptomatic. If I were to just come up with one idea to give to million hearties, in order to reduce this 1 million heart attack, focus on finding 10 million people and just telling them you're going to have a heart attack in the next 5 years. That's all you do. Just tell them, according to our data, our science, you are going to have a heart attack in the next 5 years. I bet you they will go and find a way to get themselves fixed. Because people, when they don't know the risk, and if the doctor says your cholesterol is borderline, a little bit, just lose some weight, they don't get that fire in themselves. They're not motivated. But you tell them, according to government data, we evaluated you, and according to the 1 million heart, we're obligated to tell you you're going to have a heart attack in the next 5 years. You will move people. They will just do everything they can. They listen to their doctor. They lose weight. They get a start here. Our problem is we've never done this. We've always been very community intervention, very soft, touch, and maybe it was partly our fault. I think if we can just focus Million Hearts Initiative on telling 20 million or 10 million, whatever number you come up with, comfortable with, according to our data, you're going to have a heart attack in the next 5 years, and our goal is to stop you from a heart attack. So please do something. And here is a list of things that they can do.
Well, it's a little after 9 o'clock now. We could probably go on for a long time. I would really, when we heard about the Million Hearts Initiative, I think we got so excited because, wow, finally the government is paying attention to this. And Dr. Wright's presentation tonight has just increased our enthusiasm and our excitement about this. And what we promise to do as an organization is to work with you to the greatest extent that we can to try and accomplish your goal. So thank you for coming and telling us about it, and thank the panel and all of you who came here. Thanks again, folks.